Adjustment disorder occurs when you can identify a stressor within the past 3 months of symptom onset. And it's marked by emotional distress. And the key thing is functional impairment. So it's either going to be something like social isolation or difficulty concentrating at work. Functional impairment is what makes this the diagnosis of adjustment disorder. If there is no functional impairment, then this will be a normal stress response. Counseling and psychotherapy. For a clean or minor wound in a person who has received a tetanus toxoid vaccine within the past 10 years, you don't have to do anything. But if you're unsure or it's been more than 10 years, then you give them the tetanus toxoid. And in addition to that, you can give them the tetanus immune globulin, which provides immediate but temporary immunity. The tetanus toxoid will not provide immediate immunity. It is delayed. If a patient has a dirty or severe wound, such as a puncture, avulsion, or crush injury, burns, or frostbite, and they have had the tetanus toxoid within the past 5 years, greater than 5 years ago, then you still give them the tetanus toxoid. If they have some sort of immunocompromisation, then you give the tetanus immune globulin and tetanus toxoid. Suppressed TSH during pregnancy is normal. However, if you find a TSH level less than 0.1 microunits per milliliter, then you will follow through and check the free T4 or total T4, T3 levels. The reason for this TSH change during pregnancy is because there's increased metabolic demand, and so there's going to be more thyroid hormone production. In addition to that, estrogen is going to stimulate the production of thyroxine binding globulin, which leads to a decrease in free hormone levels. This is also going to activate TSH. In addition to that, HCG has a common alpha subunit and a very similar beta subunit to TSH, so it can directly stimulate TSH receptors, providing feedback suppression to the pituitary. To manage intussusception, you're going to first do an ultrasound and see if you can find the target sign. You are going to do a enema reduction with air, saline, or iodine contrast. This is going to be both diagnostic and therapeutic. If that doesn't work, then you will do surgical intervention. Or if there are signs of peritonitis, you also do surgical intervention in that case. If you have recurrent intussusception, it happens, gets treated, happens again, then in that case you would do a technetium 99M scan looking for ectopic gastric mucosa within a Meckel's diverticulum. During emergency care, you don't need informed consent from a child's parent or guardian to proceed with the treatment. Emergency care is something which can cause severe impairment or death if the treatment is delayed. After the treatment with air enema, realize that there is still a risk for intestinal perforation with that treatment because the intussusception leads to ischemic necrosis of certain pieces of the bowel wall. And so this can lead to reduced integrity of certain parts of the bowel wall, which can then perforate once you do the air enema. So be on the lookout for this. Both hemophilia A and B are transmitted in an X-linked recessive manner. Let's review the causes of acute kidney injury. So we have pre-renal, acute tubular necrosis, and post-renal. Post-renal I'm kind of going to leave out of this review just because it's pretty easy to, I shouldn't say easy, but it's kind of straightforward to recognize when somebody has post-renal. There's some sort of malignancy, stones, or some kind of urinary obstruction, right? Prostatic hypertrophy. And in terms of the findings when it comes to BUN creatinine ratio, the FeNA, the urine osmolality, all those things can be highly variable, right? So we'll leave that out. I want to focus mostly on pre-renal versus acute tubular necrosis. Okay. Now, both of these entities can come about due to hypotension or low effective arterial blood volume. Okay. Both of them can. Pre-renal in particular. Acute tubular necrosis can have other etiologies on top of hypotension, and this includes sepsis, ischemia due to tubular injury, or nephrotoxic medications. Now, let's talk about an acute tubular necrosis. You're actually doing damage directly to the tubular cells of the kidney. So there's going to be a decrease in function of the kidney that is going to be a little bit more difficult to restore. Whereas in pre-renal, it's not damage to the cells themselves. It's kind of like a decreased arterial flow to the kidney, which is causing decreased output, more or less. Okay, so when you talk about pre-renal kidney injury, we're looking at a BUN to creatinine ratio of greater than 20. That's the first thing that can distinguish it. Whereas acute tubular necrosis is going to have a BUN to creatinine ratio less than 20, anywhere from 10 to 15. Then we're also going to look at the FeNA, the fractional excretion of sodium. So pre-renal is trying to conserve sodium, and this is an indication that the tubular cells are still working. Okay, trying to conserve it in the face of the decreased volume that's going through. Whereas in acute tubular necrosis, the FeNA is greater than 2%, so you're basically wasting salt. Okay, the tubular cells don't have the capacity to maintain or keep that salt in the body. Urine osmolality. So in pre-renal, the urine osmolality is going to be greater than 500, and in acute tubular necrosis, it's going to be anywhere around 300. Then we look at the microscopy. So for microscopy, pre-renal is going to be bland, nothing special to see there. But for acute tubular necrosis, there are going to be muddy brown casts. The management for each one. This is the interesting part right here, is when you give intravenous fluids, right, give a fluid challenge in pre-renal, you will see that increase in urine output in response to the fluid bolus. In acute tubular necrosis, because there is damage to the kidney cells, you are not going to see that urine output, right? So you're going to give them fluid, but their output is going to remain low. The time frame to see this output is 72 hours. So if after 72 hours of administering fluids, you still don't see an appropriate response in urine output, this is a clue telling us that we're dealing with acute tubular necrosis as opposed to pre-renal azotemia. You want to say hello? In this person with acute kidney injury due to tubular necrosis, you're going to be giving them fluids, right? And one of the things you have to be aware of is because they are not capable of producing urinary output, you need to be careful in terms of your fluid resuscitation. You don't want to volume overload them. And so some clues that can tell you that you may be doing a volume overload are, for example, if they start showing clinical signs of volume overload, such as pulmonary edema, you may see that from worsening hypoxia. Another thing is a hyperchloremic non-anion gap metabolic acidosis. But you need to keep in mind that because of the acute kidney injury, they will also have an anion gap layered on top of that. So a slight hyperchloremia, maybe anywhere from like 106, 108, and a anion gap acidosis on top of that because of the acute kidney injury. This could be an indicative of that, right? If their mucous membranes are moist, this tells you that they are not hypovolemic. They're reaching that level of proper hydration, and they can easily go to the level of overhydration. The treatment of the AKI is going to be elimination and avoidance of potential nephrotoxic insults such as NSAIDs, ACE inhibitors, angiotensin receptor blockers, avoiding contrast media, and adjusting all of the medications for renal dosage or for renal function. And you want to maintain their euvolemic status. If they start to become hypervolemic, then sometimes we can use diuretics. If they're hypervolemic, and on top of that, we start to see some sort of electrolyte or acid-base imbalances, or let's say they have a severe metabolic acidosis, or they're starting to have clinical symptoms of uremia, then in those cases we will do hemodialysis. We want to continue to monitor their electrolyte and acid base. So potassium, magnesium, phos, calcium, bicarb needs to be evaluated regularly. Let's talk about some antibodies used for diagnosis. So if you have a patient who you suspect has SLE, you can run an anti-nuclear antibody. However, ANA can be positive in patients who are healthy or who have other connective tissue diseases other than SLE. So there's a more specific variant of ANA, which is called the anti-double-stranded DNA. And this is more specific to SLE with a sensitivity of 66 to 95% also. Now, what other antibodies do we have? We have anti-centromere antibodies. Anti-centromere antibodies are most sensitive specifically for the CREST variant of scleroderma. Then we have anti-mitochondrial antibodies, which is to detect primary biliary cirrhosis. Then we have anti-Smith antibodies, which are highly specific for SLE, but have a sensitivity of only 25%. Whereas the double-stranded DNA antibodies that we mentioned before have a specificity and a sensitivity of 70%. Then we have anti-Rho SSA antibodies, and these are seen in some patients with SLE but are most sensitive for Sjogren's syndrome. Okay, Sjogren's syndrome. So for SLE, the ones that are associated are anti-nuclear, anti-Smith, and anti-double-stranded. The anti-double-stranded antibodies are the most sensitive of those three. Another thing that is helpful with anti-double-stranded DNA antibodies in SLE is that they can be used to follow the course of the disease. All right, so they correlate with disease activity. And there's some times where people with SLE may develop lupus nephritis. And so the use of anti-double-stranded DNA antibodies can help us confirm that it is indeed lupus that is causing the kidney injury as opposed to something else like infection, medication toxicity, or some other unrelated disease. Antihistone antibodies are associated with drug-induced lupus. Interesting. In terms of treatment for lupus, you're always going to start with prednisone. You're not starting the prednisone to keep it on board for the whole time, but you do want it to be there at least in the beginning to start to reduce the symptoms, and then on top of that you're going to add something else. So usually you're going to use hydroxychloroquine, especially if you have cutaneous symptoms, arthralgias, or serositis. Hydroxychloroquine is particularly good at treating those kinds of things. It can also help prevent damage to the kidneys and the central nervous system. So you're going to give low-dose prednisone 5 to 15 milligrams a day for a short term until hydroxychloroquine takes full effect. And there are other medications that you could use in addition to that, such as methotrexate, cyclophosphamide, but these are reserved for more serious cases and when there's end organ involvement. So methotrexate in particular is used for significant organ involvement where prednisone by itself is not able to give us an adequate response that we're looking for. And cyclophosphamide is reserved for patients with serious manifestations such as lupus nephritis, central nervous system involvement, and vasculitis. Risk is defined as looking at the probability that someone is going to develop some sort of condition over a certain period of time. So risk is usually used in prospective studies. And to understand risk is pretty straightforward. You would take the amount of people that experience the event divided over the total sample that you're looking at that could have developed that event. And you simply do the division, right? The amount of people that experience it divided by the total number of people that could have experienced it. Now, and then there's relative risk, right? And so relative risk is taking the risk of one group, which is usually the exposed group, over the risk of the non-exposed group. Now, the wording is particular here, right? If you're asked to get the relative risk for patients with exposure compared to patients without exposure, right? Compared to part is where the relative comes in, and the compared to the patients that come after that statement will be in the denominator. The first group of patients that is mentioned will be in the numerator. The odds ratio is different. So now we're not taking a prospective look, we're taking a retrospective look. So we're looking at number of cases of a particular event, okay? And so you're gonna have a group of people that have the event, and then a group of people that did not experience the event. And what you want to look at is the relative exposure to a certain exposure, right? Whether it be smoking or acetaminophen use or whatever it may be, okay? So what you're going to do is, so usually the formula for this, the way I first learned it was using the 2x2 contingency table, and I've talked about this in a previous recording, and drawing an X through it so that you're doing A times D over B times C. Now, that is a mathematical manipulation to a different formula that you can use. And this different formula I like a little bit better because it makes more intuitive sense for me. And so basically what you're doing is you're taking the event group, right? The group that the event occurred in, and you're going to calculate the odds of exposure in that event group. So that's going to be the number of people in the event group that were exposed divided by the number of people in the event group that were not exposed. And that's going to give you your odds in the event group. And then you're going to take that number and divide it over the odds of the people that were not in the event group. Okay. And so the people that were not in the event group, you're going to do the same thing. The amount of people that were exposed divided by the people that were not exposed. And that is going to be your odds ratio that you're going to get at the end. You can realize that. So if we're following the contingency table, this would be A divided by C over B divided by D. And you can realize that that's the same mathematical application as A times D over B times C. Now, a correlation coefficient can show you the strength of association between two variables. And one of them can be named the outcome variable, which is the one we're interested in, and the predictor variable, okay? Now, there's another determination that we can make from this number. We can get the coefficient of determination. The coefficient of determination is the percent of variability in outcome that is explained by the predictor. And this can simply be worded as how much of the variability in X is explained by y. The way you determine the coefficient of determination is by squaring the correlation coefficient. So if you have a correlation coefficient, let's say of positive 0.75, you do 0.75 squared, which is going to give you, nope, that's not right. 0.75 squared is 0.56, so it'd be 56%. So 56% of the outcome of the, 56% of the variability in the outcome is explained by the predictor. Attributable risk can take a total of 3 variations, with 2 of them having an added layer on top of the basic attributable risk. So let's talk about basic attributable risk first, also known as risk difference. Basically what this is the difference between incidence between an exposed group and a non-exposed group. So you get the risk of developing whatever in an exposed group minus the risk of developing whatever in a non-exposed group. And that is your attributable risk. The next is your attributable risk percent. So this describes the contribution of a given exposure to the incidence of a disease in relative terms. Still trying to figure out what that means. But this is basically going to be the same. You're going to calculate for the same attributable risk that you got before. This time, you're going to take that number and you're going to divide it by the risk in the exposed group. Okay? So you take your attributable risk, you divide it by the risk in the exposed group. And you times that by 100 to get the percentage. Okay? Let's start adding some numbers to this. So let's say I have 200 people. And out of those 200, 120 of them are smokers, 80 of them are non-smokers. So that's our exposure right there, smoking versus not smoking. Let's say out of the 120 smokers, 60 of them develop lung cancer. Let's say out of the 80 non-smokers, 20 of them develop lung cancer. To get the attributable risk, we would look at the exposed group, the 120 that are smokers, and we would say the incidence of lung cancer here is 60 over 120, which is 0.5. And then we would look at the incidence in the non-exposed group, the non-smokers, and we'd say that's 20 over 80, which is 0.25. And we would subtract 0.25 from 0.5 and get an overall attributable risk of 0.25. Okay. Next, to get the attributable risk percent, we would take that 0.25 and we would divide it by the 0.5 that we got earlier from the 60 over 120, right? The incidence in the exposed group. And we would get 0.5. The percentage, 50%. So the attributable risk percent in this case would be 50%. Next, we have the population attributable risk, which is the impact of exposure on the entire study population. Okay, so now we're going to start using the 200, the total population, both exposed and non-exposed. And what we're going to do is we're going to look at the overall incidence rate in the whole population. Let's say for this case, we said 60 smokers got lung cancer, 20 non-smokers got lung cancer. Overall, in the whole population, 80 out of 200 got lung cancer. So we're going to take that 80 over 200, and from that, we're going to subtract the incidence of the non-exposed group, 20 over 80. Then we're going to take that number, that numerator right there, and we're going to divide it by the incidence in the overall population, again, the 80 over 200. And then we're going to times that by 100 to get a percentage. And what we end up with is 37.5%. So this is the population attributable risk percent. Remember that attributable risk can also give you another data point, which is number needed to treat or number needed to harm. And it is simply the inverse.